One.
Well, I want to welcome you all to the fourth international installment of our international webinars, sponsored by the World Federation of Athletic Training and Therapy. My name is Glenn Bergeron. I'm the president of the World Federation of Athletic Training and Therapy, and I'll be your host today for today's presentation. Once again, we're so pleased with the response of these webinars. We have almost 200 registrants from 17 countries from this webinar, and we're very, very pleased to offer this presentation. Today's presentation will look at the values and benefits of working as part of an interprofessional healthcare team. The presentation resonates perfectly with the mission of the World Federation of Athletic Training and Therapy. The mission statement is one where we state that athletic training seeks to be and wants to be an integral member of the international healthcare community. And our mission is to provide leadership, cultivate collaboration, champion the athletic training and therapy profession globally, and also contribute to a healthier world overall. So this interprofessional concept works very, very well for us. And so we're very pleased to give you this presentation. The presentation is entitled Perceived Satisfaction and Interprofessional Collaboration in International Sports Science and Sports Medicine. It's presented by two distinguished guests, Dr. Anthony Breitbach from St. Louis University in St. Louis, USA, and Dr. Gert Ulrich from Carium Foundation in Zurich, Switzerland. They will be introducing themselves as part of their presentation, so I don't want to steal their thunder, except to say that they are both recognized as international experts on the topic of interprofessional collaboration in healthcare. Before we go on to the presentations, there's a few housekeeping notes. First of all, the session will be recorded and uploaded on the World Federation website for future reference. The presentation will be approximately 60 minutes, after which time we have allotted 30 minutes for questions. Questions can be submitted in writing during the presentation using the Q&A feature. We will be monitoring that. We ask that you look at previous questions that have been posted before you post your own. If previous questions is the same or similar to what you wanted to ask, simply hit the like button on that previous question. This will increase the priority of that question and the likelihood that we'll get to that question in our limited time for questioning. Once the webinar has ended, you will be sent a very short evaluation questionnaire, simply 4 questions. We really would appreciate if you would take a few more minutes of your time to give us your feedback. It really helps us in determining future presentations and what we can improve and what we're doing well. Also, certificates of participation will be sent to you online within a couple of days following this presentation. So I've taken enough of valuable time, so I would like to welcome Drs. Breitbach and Ulrich to the screen for this presentation. And I will do a stop share at the moment.
Thank you, Glenn. And it is a pleasure to be here as a guest of WFATT to present our research on job satisfaction and interprofessional collaboration in international sports science and sports medicine. As we move to our disclosure statement, in compliance with the continuing education requirements, we present no financial or other associations with companies that have direct financial link to the topic of this presentation. Our agenda for today, we'll present an overview with some background information. We'll review our methods. We'll go through the results and conclusions from 2 separate instruments that we used in our research, and then we will also present some open-ended discussion points at the end of the presentation. To tell you a little something about myself, I'm originally from Iowa. I went to my school at the University of Iowa in the early 80s. And then I worked as an athletic trainer for 22 years before moving. You can advance it there. There we go. Worked as an athletic trainer for 22 years, the last 7 of which I was the head athletic trainer at St. Louis University. I completed my PhD in 2007 and moved over to start the Master of Athletic Training program at St. Louis University. where I got involved with interprofessional education, teaching, scholarship, and those types of things. I'm on several national committees, international committees. And then also one of the cool things about what we do at St. Louis University, we got involved with WFATT, and we actually have clinical exchange programs with both Athlone Institute of Technology in Ireland and University Camilo Jose Cela in Madrid. So this is a picture of me at the end with several of the UCJC students. I will turn it over to my colleague Gert, and he can tell you a little bit about himself.
Yeah, thanks Tony, and thanks Glenn for invitation. Good evening from Zurich, Switzerland. Delighted to present here together with Anthony. And to introduce myself, you see here a southern part of Germany, and below you see Switzerland and Austria on the right. And right now I'm commuting between Heidelberg and Zurich. Heidelberg, where my family lives, and Zurich, where I'm working right now. And Heidelberg is a beautiful city, and where I did my study program. I studied sports science with a focus on prevention and rehab, and also exercise physiology and sports medicine. And this is the Sports Institute in Heidelberg, where I studied and also worked afterwards. And you can see here now the Olympic Training Center, where I also worked as a diagnostician, especially in the area of endurance performance and speed, agility, quickness. And this is a building where I also did my investigations for the PhD. It was about total hemoglobin mass measurements in youth elite athletes. And afterwards, I worked at the University Hospital in Heidelberg in the study program Interprofessional Healthcare. And in parallel, I worked at the Sports Institute as a lecturer and a researcher. In 2017, I moved to the next beautiful city in Zurich. And here I'm the project manager of the first Swiss interprofessional training ward. And I'm a researcher at the Careum Foundation as well, Department of Education Management. And you see here the beautiful Careum campus in Zurich. So that's for introducing that's me speaking, for introducing myself. Let's move on to the general objectives of our study. You know that healthcare should transform from a multi-professional to an interprofessional model. And although evidence is challenging, the IPC, that is interprofessional collaboration, has great potential for improving health of population, improving patient experience of care, reducing cost of healthcare, known as the triple aim, presented by Berwick et al. 2008. And there's another aim, it's the quadruple aim. So the quality of life of healthcare workers is also important to improve via interprofessional collaboration. So our objective is, in general, as a prerequisite, professionals in sports science and sports medicine should have positive experiences and attitudes in interprofessional education, that's IPE, and interprofessional collaboration. However, data are rare on IPE, IPC, and as well to the link to the job satisfaction. And further, no data exist from an international perspective. So the next general objective is to date no international perspective on IPE, IPC, job satisfaction, including various healthcare professions in sports science medicine, has been published thus far. So in detail, our objectives were to explore social demographic connections on IPE and IPC between various sports science, sports medicine professionals in healthcare from an international perspective, and further interprofessional perceptions and attitudes to generate approaches for the development of IPE that links sports science, sports medicine with interprofessional healthcare to enhance collaborative practice. So we wanted to know, what do you think about interprofessional perceptions and attitudes? And how this is the case in professions in sports science and sports medicine. And last but not least, we wanted to have a link to the job satisfaction, and we wanted to explore the job satisfaction of sports science, sports medicine professionals from an international perspective. And we were asking which factors influence job satisfaction most. So these were our objectives. And to be on the same level, I would like to give you two definitions before we start with detailed background. Interprofessional collaboration occurs when multiple health workers from different professional backgrounds work together with patients, families, carers, caregivers, and communities to deliver the highest quality of care. So it's all about to overcome professional silos, moving away from monoprofessional or multi-professional. It's interprofessional, and the patient is seen as a part of the team. And the interprofessional education, there are several definitions, and we thought this would be the most suitable for us. Interprofessional education occurs when students from two or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. So the difference to monoprofessional or multi-professional education is each year sit in a lecture beside athletic trainers or PTs or OTs, but you don't interact with them. So this is multi-professional, and interprofessional means that you learn from, with, and about each other, and you interact with students from other health professions. So let's dive a little bit deeper into, into the theoretical background. We know that interprofessional collaboration is beneficial for patient outcomes, for health, for the health of the patient. And as I told you, the triple aim to improve the health of population, patient experience of care, reducing cost of healthcare, and improving the quality of life of health professional members. So, and this is also recommended in the field of sports science and sports medicine, as supposed by several authors like Anthony and others. And in particular, you know, athletic trainers and athletic therapists are seen as a vital part of the sports medicine healthcare team. You know, athletic trainers have a wide spectrum and accompany the patient all the time and have several tasks like in prevention, emergency care, diagnosis, and rehabilitation. And it was shown that athletic trainers interact with other healthcare providers, with several healthcare providers, and they should also have a seat at the interprofessional table. But we know from research or from papers that most included professions in IPC and IPE are medicine, nursing, OTs, PTs, pharmacy, and social work. And data on sports science, sports medicine professions or athletic trainers, athletic therapists are rare. But there are some, Anthony, and could you please give us some more details about the papers?
So like Gert talked about that, we identified the importance of interprofessional education and interprofessional collaboration in sports medicine and sports science. However, there are definitely some challenges with that. I think, you know, I think Manspeaker and Hankemeyer realized that in their research show that there was challenges with engaging in IPE, having other team members understanding our roles with scope of practice. Not everyone views collaboration the same way. And then, you know, really developing communication structures and educational opportunities. One of the solutions for this is to develop interprofessional education in our education programs to help give people this skill set moving forward. So then on the next one, so when we talk about interprofessional collaboration in sports medicine settings, there are definitely a set of challenges, and some of them are inherent to collaboration. Another one are just inherent to delivering medical care in sports settings. So if you, a paper that I did with, a review paper that I did with Simon Fletcher and Scott Reeves in 2017, we found that there were several key themes that really came out of the collaboration literature in sports medicine internationally. Issues of professional dominance, you know, where are the historical structures of dominance within medicine and sports medicine, status imbalances, how you have to negotiate kind of roles with other providers on the team, and kind of the professionalization of what you do. You know, I think Rick Burkholder has called it jumbotron sports medicine sometimes, and when everybody knows what's going on. That doesn't generally happen in other fields of medicine. Go to the next one. Also, there are also some recent studies in the areas of IPC and IPE focus really more on North America and the United States, but those are primarily on athletic trainers and not the rest of the international sports medicine team. Move on. Okay. There's really nothing that's really looked at internationally how sports medicine providers have interacted in interprofessionally and collaboratively in education. We understand that some of this is very difficult because there is a wide diversity globally on how these professionals work and interact with each other as far as professions, as far as different healthcare structures, also the high-profile nature of athletics, and these diversity of healthcare systems and payment models are really crucial factors that contribute to these differing operational models. One of the things is this international diversity is really evidenced through really hierarchies, professional regulations, but also the titles and definitions of professionals in sports medicine and sports science. We shared some definitions from different regions of the world, and how people view themselves is really based sometimes on how they define themselves publicly. And we're going to show a few of those definitions here. So this global diversity really identifies the need to really understand roles and responsibilities, and to be able to communicate across these different demographics internationally from country to country. Let's take a look at some of the definitions. So in the United States, this is the NETAs and kind of the official definition of athletic trainers: highly qualified, multi-skilled health professionals who render service under the direction or collaboration of a physician, and part of the healthcare team. Athletic trainers includes primary care, injury, illness prevention, wellness promotion, education, emergent care, examination, clinical diagnosis, and therapeutic intervention and rehabilitation of injuries. And then here's how physical therapists describe themselves as movement experts, really creating treatment plans that manage pain, chronic conditions, recover from injury, and prevent future injury and chronic disease. So it's really focusing more on exercise and hands-on care. Then we look at Canada, where the athletic therapists, their definition really focuses on probably a little bit more of athletes than the United States definition does, whereas in the sports medicine model of care. And then another profession that is fairly unique to Canada as far as North America goes is kinesiologists, and they have a related function within the sports medicine team, but they're a different discrete profession from athletic therapists. And then when we look at Europe, and we use the European Union flag, but then Gert told me that Switzerland is not in the European Union, so we made sure that was well represented on there. And technically, England is still in the European Union for about a week or so, a month or so. Ireland, certified athletic therapists, work in a variety of settings. They kind of identify 4 main areas: injury prevention, on-field emergency care, injury assessment, diagnosis and treatment, and rehabilitation, reconditioning, and kind of recognizing the variety of workplaces that athletic therapists and I really work in. There's many other definitions across Europe of different types of sports sports rehabilitation therapists, those kind of things, but we chose to pull a physiotherapy definition there. And then there's in Germany and Switzerland, sport and exercise therapy that really focuses more on kind of reconditioning and addressing the unique conditions of exercise therapy and sport when it comes to different individuals. So these are all these are really, really different definitions. So sometimes to be able to understand roles and responsibilities, you kind of need to understand where that person comes from and how they define themselves. And that's one of the things that's important to recognize as we move through this this study data. I'm going to turn it over to Gert.
Yes, let's move on with another focus we want to set is the job satisfaction and the link to IPE and IPC. We know that there's a high demand for professionals in various health systems worldwide. E.g., there's a shortage in nurses in Germany or also in Switzerland. There are shortage of health professional workers that are compensated only by workers from also from foreign countries. And in view of this shortage, the job satisfaction in healthcare professionals is really an important factor in counteracting this and fighting this shortage. And we know from different papers that I show you on the next slides in more detail, that the job satisfaction of healthcare professions can influence the quality of care in the healthcare system. We know that interprofessional collaboration can influence the quality of care in the healthcare system, and as well the job satisfaction does. And for us, it was very interesting to build the link between those two topics, IPC, IPE, and job satisfaction. To provide you some details, some informations, I would like to cite some of the papers, and Tony will go into detail with these papers. As I told you, we know that healthcare professions have a high workload, but it may be that their work is not very appreciated. So the worst case is they are overworked and underpaid, and the work is not recognized. It may be that the burnout is not far away. And what does this have consequences if you have, or if there is a low job satisfaction? High workloads can reduce patient safety. Low job satisfaction can be associated with increased staff turnover and more frequent absences from work. And this goes along with higher costs and poorer clinical outcomes, or maybe burnout. So I think it's really important to avoid low job satisfaction and try to improve job satisfaction. And this should also be true for professions in sports science and sports medicine. But we have rare data, and so we need to know how high or low job satisfaction is in sports science and sports medicine. And we need to know which factors determine job satisfaction to modify them. Let's go on with job satisfaction research. Due to the importance of job satisfaction on the performance of professionals and the healthcare system, job satisfaction has been assessed in several studies in different healthcare professions. As my colleague from Heidelberg and a study of mine, we did research, or my colleague Gert did research in healthcare professions like primary care physicians, practice assistants, dentists, and we did a study about therapists, nurses, and diagnostics. And yes, most of the investigated health professions are physicians and nurses, but we don't know very much about job satisfaction of professions working in sports science and sports medicine. And again, especially from an international perspective. And if we know this, how high or how low job satisfaction is, which factors determine job satisfactions, we can derive strategies to improve the attractiveness of job profiles in some healthcare professions. And Tony, you studied some further research.
I apologize, I was muted. Looking at some job satisfaction research in athletic training, Christy Eason and colleagues published this multi-level model in 2018 regarding working around a work-life interface and its influence on job satisfaction. And some of the factors that kind of work into that are sociocultural, organizational, individual factors. And often those do not work discretely. They all contribute as a whole to that work-life interface, which hopefully that it can impact both outcomes for the individual, create better job satisfaction for the individual, create a better staff and function as a team in the organization, and then overall create a better sociocultural component amongst the population in the profession. One of the things that's important is that with this multi-level model, you really look at kind of a multi-level intervention also. So maybe making one little change probably will not change the entire culture of a system. You need to look at kind of addressing it in several ways. As we move on to the next one, Stephanie Mazarol and colleagues identified some barriers to professional commitment, which was another kind of an aspect of job satisfaction. And really, in that survey that was published in 2015, they looked at kind of some organizational components, like things like workload, things like workplace climate, resource allocation, and then also individual things like life stage and kind of where people are at in their life continuum. They also looked at in another paper looked at the role of gender and sex in employment setting, and traditional settings were shown to have which are collegiate in the United States, collegiate, high school, and professional, are shown to have the largest struggle with work-life conflict, but males and females really showed to be really perform very similarly with regard to willingness to leave, is one of the factors they identified there. We can move on to the next one. We looked at Terranova and Henning looked at different factors that affect job satisfaction among collegiate athletic trainers. And they found 8 factors all that are listed here all contributed to that. They did find that the best predictor, the nature of work was actually the best predictor of job satisfaction factors for these athletic trainers. However, they were not affected by level of competition as far as the NCAA level, or the actual title of their job. Really did not have it's really the nature of the work instead of the title of the job. That's one of the biggest things to contribute to that. If we look at the next slide, Bill Pitney looked at factors, Giacobbe looked at factors that influence burnout, things like depersonalization, personal accomplishment, emotional exhaustion are factors there. And then Pitney, in his survey of high school athletic trainers, recommends a holistic approach based around kind of the common ethic of professional responsibility, and engaging in this cycle of providing respect, giving both extrinsic and intrinsic rewards, and then the ability for rejuvenation, whether it be a more balanced schedule during the season and during the work time, or giving them time away from work to be able to rejuvenate in the off season. Move on to the next one. We did want to include a couple other professions in this. So we looked at a study of physiotherapists in Australia, and they really identified in this was that there is their ability to kind of control their financial aspects of their job and to have coherent career pathways are really two of the things that really contribute to job satisfaction among physiotherapists. Another study in Poland looked at some of these individual factors such as work-life balance and weak financial position and things like salary and housing and stuff that really contribute to job satisfaction there. And then one more study about physiotherapists. And this really looked at, once again, career stage. Move on to the next slide. Move on to career stages. The need for career pathways, peer mentoring and support. Those are all factors that can contribute to improved job satisfaction. I'm going to turn it over for the methodology to Gert.
Yes, thanks. So far to the theoretical background, and I want to give you some details about our methods. First of all, you know, Tony and me, we created an online survey, and before I move to this, I will say something about the recruitment of participants. We use our personal network, so we direct emails to our personal network, or we use the email distribution lists through professional organizations like European College of Sports Science, Sports Medicine, ACSM, WFATT, NADA, and CATA, and as well as Swiss Sports Science Association or Sport Science mailing lists in Germany. We also use social media like Twitter, Facebook, LinkedIn, or Xing, and collected data in USA, Canada, and several European countries. And you see the countries, Germany, Ireland, and so on, Switzerland. And as we had different response rates from these countries, we decided to merge those data to Europe. So we have 3 regions investigated: USA, Canada, and Europe. And here's our instrument. It's called the IPC in Sports Science and Sports Medicine survey. We asked for socio-demographics like age, gender, employment, profession, how many professions do you work regularly, or how many hours per week are you working. And further put into this survey the UWE, University of West of England, Interprofessional questionnaire to assess attitudes and perceptions towards IPC and IPE. I show you on the next slides in detail. Further, we used the Walkup Wall job satisfaction questionnaire. It's easy to handle questionnaire and very popular in research to use this questionnaire. And at the end, we had open-ended questions, e.g., in my opinion, the title athletic trainer indicates the following professional roles and responsibilities. So it's interesting to see what USA, Canada, and European countries think about this. And another open-ended question was, what else would you like to tell us? And before survey dissemination, we validated this survey by 12 international experts from our personal network from different countries. And we also wanted to see, is it easy to handle in also non-English speaking countries, e.g. Switzerland, Germany, and so on, the non-native speakers. And they gave us valuable inputs and feedback to improve our data and said that it should be okay also for non-native speakers. This is the University of West of England Interprofessional questionnaire, in short from UWE. And this questionnaire consists of 4 scales. This is communication and teamwork scale, interprofessional learning scale, the interprofessional interaction scale, and relationship scale. And every scale has 8 to 9 items and is rated via our Likert scale from 1 to 4 or 5 respectively. So 1 means strongly agree, 4 means strongly disagree. And I have an example here from the communication and teamwork scale. So you see here all the items, e.g. I feel comfortable working in a group, number 5, or number 9. I'm comfortable expressing my own opinions in a group, even when I know that other people don't agree with them. And what they did was, first, of course, we did the reverse scores for some items, and we created a sum score for each respondent and scale respectively. That means if we have a respondent in communication and teamwork scale who said, okay, strongly agree, and it was rated 1, 1, 1 in every item of this scale, you have a sum score of 9. And it did this for every respondent and every scale. And afterwards, we classified those attitudes and perception as positive, neutral, or negative attitudes. Okay, let's show the next instrument, the walk-up-wall job satisfaction questionnaire. As I told you, it's very easy to handle, very popular, and often used scale in research. And this questionnaire consists of 10 items in total and 9 aspects of job satisfaction and the overall job satisfaction. So each year it's questions about physical working conditions, freedom of working methods, recognition for work, hours of work, and so on. And again, we used a Likert scale with ratings from 1, extremely dissatisfied, to 7, extremely satisfied. And you know that higher scores indicate higher satisfaction rates. You can see it here again. The 9 items from 1 to 9 describing different aspects of work. And this is the most important, the 10th item, taking everything into consideration. How do you feel about your job? And you see here the Likert scale from 1 to 7. And item 10 is also known as the overall job satisfaction. Okay, let's move on to the stats we used before we move to results. This is maybe a little bit unpleasant slide for you, but I like to show you what we computed on statistics. We used for the UWE, Interprofessional questionnaire, we used the 5-factor analysis of variance. We wanted to see, or we asked ourselves, if gender, age, region, number of self-identified professions, number of professions regularly interacting in own work has impact or an effect of each of the UWE subscales. The number of self-identified profession means if I identify myself with a sports scientist. So this is, I identify myself with one profession. If I say I'm a sports scientist, but I've also worked as an athletic trainer, or I'm a physio, I identify myself with now, in this case, 3 professions, and this is 2 or more. And we have another variable here, number of professions regularly interacting in own work. I think it's easy to understand with how many professions do you regularly interact in your own work, and we build these groups to compare. So for the job satisfaction scale, we used 10 ANOVAs, and we asked if there are any differences between the regions, USA, Canada, Europe, concerning the 10 job satisfaction items. Due to multiple testing, we used the Bonferroni adjustment with an adapted significant threshold, 0.005. And also we wanted to know, as I told you, the connection between IPE, IPC, and job satisfaction. We wanted to know if there is an influence of personal experience in IPE and IPC on the overall job satisfaction. Again, the use of Bonferroni adjustment. And to find out which items predict overall job satisfaction most, we used a multiple linear regression analysis and looked if selected social demographics like gender, age, scope of work, and all the variables of a job satisfaction scale influence overall job satisfaction. In general, we checked normal distribution and the conducted post hoc tests in the ANOVAs if they were significant, and checked for variance homogeneity. And we considered ethics via IRB St. Louis and the Cantonal Ethics Committee of Zurich. Well, as you have survived this slide, Tony, please move on.
We'll move on to the results section. I'm going to start off with kind of describing how the descriptives came out of the study. So as we move on to the next slide here, as you can see, our responses, we had 320 total full responses to the survey, of which 143 were male and 177 were female. In both the USA region and the Canada region, the females were well over 50% of the males, whereas actually in Europe, 72% of the respondents were male. As you look, most of our respondents were below the age of 40, and that's probably not too surprising. The fact that this is the practicing setting might be more configured for younger individuals. So move on to the next one here. Employment and working hours. We broke them down in below 20 hours per week, 20 to 42, which is basically, at full time or less than full time, and then kind of an overtime group. And as you notice, the overtime group is 40.6% of the respondents. The type of employment was quite interesting. In the United States, it was really 90% of the individuals is employed by some organization, whether it be an institution or a medical provider of some sort. Whereas it's split up a little more evenly in Canada and Europe, where we have self-employed being a much greater piece of the distribution. In Canada, it's 36.9, and in Europe, it's 39.7. So we look at the primary professions, and they're kind of going to be as predicted. I think athletic trainers and physical therapists are the bulk of the professions represented from the US. Canada, athletic therapists and kinesiologists or kinesiotherapists. And then in Europe, athletic trainers and athletic therapists, but they were spread out quite a bit over a bunch of different professions in Europe. The thing is one of the things we've noticed with self-identified professions, that in the United States, that a much greater amount of persons identified with a single profession as compared to Canada and in the Europe group. I think this could be could be the strong alignment that the United States has with accrediting bodies and kind of siloed professions. Whereas I think maybe in more of the international structure, there is the ability to gain additional trainings and those kind of things a little bit easier than in the structure of the United States. Who we interact with, I think physicians, athletic trainers, and physiotherapists interact with each other most often in the US. Very similar also in Canada. But then in Europe, there's a lot of statements about interacting with sports scientists, strength and conditioning coaches, human performance specialists, and physical therapists in Europe. This is the number of professions interacting with regularly in your own work. So if you look at, you know, these are all fairly similar looking tables. I would say the one thing in Europe, the 1 to 3 group is quite a bit higher. And in Canada, the 4 to 6 group is higher. So we didn't really run the statistics to really determine if there's a significant difference between these, but visually you can see there's a little bit of variance, but the 1 to 3 and 4 to 6 are still pretty the two sizable ones. When we talked about those questions regarding interprofessional collaboration, most of the people in the study viewed interprofessional collaboration as either having a very positive or mixed impact. They have had interaction with that. Very low amount said it either had a negative impact or they had no experience at all with interprofessional collaboration. We're going to expand on that further when we do more of the analysis. And then interprofessional education. One of the things we realize that is the professional education is the blue bar in each of these. We understand that it's not, IPE has not just been recently been adopted by many of the accrediting bodies in athletic training and even physical therapy for that matter. But we did notice that in Europe and Canada, there's a much greater understanding that a lot of their continuing education is multi-professional and interprofessional as compared to as much within the United States. So if you look at the gray column includes both professional and post-professional education, whereas the orange bar represents continuing education. So I think that could be, once again, it goes back to the focus on profession, single professions in the United States, and maybe there's a lot of the continuing education courses in other countries are less about specific profession and more about topics. I've gone to several conferences and outside of the United States, and I noticed that many of the topics, as far as like the IOC conference, those types of things like that, ECSS, are really based around topical areas. Even for that matter, the WFATT conference we did in Dublin, it was really, we did it with multiple professions, based around the hip. I remember when we did that. So next, I'm going to turn it over to Gert, and he's going to talk about some of the analysis he ran.
Okay, statistics again. Now you see here the results of the UWE in the professional questionnaire. To remind you, this was a 5-factor ANOVA. And I want to go through this step by step, as there are many results on this slide. First of all, you see the communication and teamwork scale. And you see here below on the x-axis the region, USA, Canada, and Europe. And it's depicted via box plots. And the median is the horizontal thick line. So that means that 50% of the data lie above this median and 50% of the data lie below this one. And in the gray boxes, there are 50% of the data. What we see here on the communication and teamwork scale is we have very positive or clear positive attitudes and perceptions to communication and teamwork scale. And you see here on the right, the classification, positive, neutral, and negative. But we didn't find a difference between the regions. But we can say the communication teamwork scale is rated on the average clear positive. And the next scale is the interprofessional learning scale. So you can see here at first that the attitudes on interprofessional learning are very positive again, and especially in USA, they are really very, very positive. And we saw also differences, significant differences between USA and Canada, USA and Europe. And so you can say USA was the most positive in interprofessional learning. So you can say, for instance, learning with students from other health and social care professions is likely to help to overcome stereotypes that are held about the different professions. Or you can say that learning with students from other health and social care professions is likely to improve the service of patient and clients. So again, the very positive attitudes in USA may be due to that IPE has been pushed forward in the last years in the USA compared to efforts in Canada or Europe, e.g. by Anthony. And let's move on to the interprofessional interaction scale. And this is a scale that's asking for are there any stereotypes, or is there a hierarchy, or are there equal respects, or it is easy to communicate openly with people from other health and social care disciplines. And it's interesting to see that the attitudes and the perceptions are in the negative sector. And this means, oh yes, it seems like respondents perceive stereotypes, hierarchies, no equal respects, and not an open communication. And there was effect of the region again, and the respondents from Europe were less negative compared to Canada and USA. And we were thinking about why this may be the case, and we thought that in Europe, many persons are self-employed and maybe have fewer interprofessional interactions and can have fewer negative experience, but this is highly speculative. But it's interesting to see that on average there are negative perceptions on the interprofessional interaction scale. The last scale is the interprofessional relationship scale. And you see here that the attitudes are clear positive again in all regions, and there was no difference between the regions. And you can say again on this scale, for instance, I have equal relationship with peers from my own professional discipline, or I am confident in my relationships with people from other health and social care disciplines. So it's pleasant to see that the attitudes are on the average clear positive, with the exception of the interprofessional interaction scale. And as you can remember, this is a 5-factor ANOVA, so we detected more effects. Just to give you an idea, we detected significant effects of age, and in scales A and D, and we looked for the group comparisons and saw that older respondents were more positive compared with their younger counterparts. So the older, over 40 years, more positive attitudes compared to 20 to 39 years old. And we also saw an effect of gender in scale D. Males were more positive when compared to women. And no effects could be detected for the number of self-identified professions. So this has no effect on perceptions on interprofessional education collaboration, and also the number of professionals regularly interacting in own work. So it doesn't matter if you work regularly with 1 to 3 or 4 to 5, 6, 7 other professions. This has no influence on perceptions of interprofessional education and collaboration. So this is a pattern that's shown in several other studies. So positive in scales A, B, and D, and neutral to negative in scale C. But I was very surprised that it was very clear positive here in A, B, and D. To conclude the descriptives and the IPC, we can conclude that differences in several demographic variables could be identified, as Tony told, e.g. type of employment, number of self-identified professions, personal experience with IPE. And just on the last slide, on average, clearly positive attitudes towards communication and teamwork, interprofessional learning, and relationship were documented. And it seems like that health professions in sports science, sports medicine are well equipped for interprofessional collaboration. However, only in interprofessional interactions, negative perceptions were found. And it seems like the systems that where the respondents work in do not really support IPC. Yes, that's what I told you right now. In conclusions, professionals in sports science, sports medicine clearly value IPC, and IPE is positive attitudes, perceptions, but they feel that the systems do not support IPC in their working routine. And thereby the interregional exchange and learning from each other could be promoted, and the visibility of IPE and IPC in sports science, sports medicine. It seems like that we have similar challenges in Europe, USA, Canada, and it would be interesting to learn from each other, from the different regions, or in international or national networks, organizations, committees, and boards to exchange each other and to learn from each other with the aim that athletic trainers, therapists, and other health professions in sports science, sports medicine have a seat at the interprofessional table. So let's move on to the overall job satisfaction results. And first of all, I would like to guide you on the right through this table. You see here on the right column, the overall job satisfaction. You know, this is the 10th item of the WCWC scale. And you can see on the left here, socio-demographic parameters, and we can move on step by step. You see here, numbers around about 6, and this was 1 was extremely dissatisfied and 7 was extremely satisfied. So you can see here numbers around about 6. This is a very high value, and you can say the satisfaction, job satisfaction is pretty high, and is very high. And according to the items on the left, you see here gender, there seems to be no difference. You see the age, slight difference. We didn't use statistics. The scope of work, it seems like that those who work below 20 hours seems to be not that satisfied with their job compared to those who work 20 to 42 hours. Number of self-identified professions, 6.1, 6.1. There are no differences also in the number of professions regularly interacting in own work. And the other 2 items are those who we implemented in the ANOVA. So we wanted to know if the personal experience with IPE and IPC have impact on the overall job satisfaction. And there was no significant influence of personal experience with IPE on overall job satisfaction, but we detected a significant influence of personal experience where IPC impacted patient-client outcomes on overall job satisfaction. As you can see it here below on the right, we have the experience of IPC. Those who responded yes have significant higher values. Only it's slight, but it's significant difference compared to those who have mixed impact. You see here those who reported negative impact, those 3 respondents, they have 5.0, but as you can imagine, the low number of respondents, there is no chance to have really good statistics. And that's why we have a significant difference between those who reported positive impact compared to those who received, who reported negative impact. Okay, to move on, I just have to organize my screen here. Sorry for that. The region-specific analysis for job satisfaction gave the table below, and many numbers. Again, I will guide you through this table. You see on the left the items of the job satisfaction scale, and you have here below the overall job satisfaction. And in the total sample, you can see here that, again, these values, these are really, really high compared to other studies. In our healthcare professions, there are numbers from 4 to 6 in between, and we have numbers like over 6 for the overall job satisfaction for the total sample. This is really, really high, and it's a great job satisfaction. And the freedom of working method was rated most positive with this 6.3. So you can choose your own working methods, and it seems like really, really great in the respondents. The lowest is not surprisingly, it's the rate of pay. It's 4.8, and also a smaller number is with 5.3 the hours of work. So if you would combine this, you can say, okay, underpaid, overworked, but again, these are not bad values. And this is the total sample, and let's move on to the region-specific differences. You can see here we have a trend to a significant difference between Europe, rate of pay 5.2 versus USA 4.5. So it seems like the respondents from Europe are more satisfied compared to USA. And the same was the case for the overall job satisfaction. We have again a trend in a statistical significant difference between Europe and USA. But again, these values are pretty high. These are from 1 to 7, and 6 is really very high. To conclude this, on average, respondents are most satisfied with the freedom of working methods and most dissatisfied with the rate of pay and hours of work. And it seems like that there are specific differences within the section satisfaction, the rate of pay, and the overall job satisfaction between Europe and Canada. So for the last slide of the statistics, I would like to present you the regression analysis. So the question was, which items predict overall job satisfaction most? And you see here the results of a stepwise regression analysis. We implemented 7 steps. And you can see here the items that were implemented in this analysis, and that says that those items predict the overall job satisfaction. And we have 3 variables, 3 items of the Walkup-Wall questionnaire that are the most powerful items to predict overall job satisfaction. And these are the opportunity to use abilities. So if I go to work, I work as a sports scientist or athletic trainer, I would like to use what I've learned. I would like to use my abilities. And the second one is the recognition you get for good work. So it's important for health professionals in sports science, sports medicine to get the recognition for good work. And the physical working conditions shouldn't be too strenuous. You can say also the other items may influence overall job satisfaction, like the amount of variety in your job, the freedom to choose your own method of working, your colleagues and fellow workers. But it seems like the items, the first three items here, have the most powerful impact, and it's important to consider these if we talk about job satisfaction in health professionals in sports science and sports medicine. So to conclude, there seems to be a significant influence of personal experience where IPC impacted patient-client outcomes. And there seem to be region-specific differences with the satisfaction, the rate of pay, and the overall job satisfaction. And to improve job attractiveness in sports science, sports medicine, the items should be addressed, in particular also the other items, of course, but these in particular, and this is opportunity to use abilities, recognition for good work, and physical working conditions. So this is a conclusion also to job satisfaction and the connection to IPE, IPC. And we have some further results, Tony, to the discussion.
And it was really neat how that some of the job satisfaction data really aligned with some of the previous research that was done that we presented earlier in the background section, where that nature of work and really kind of that reward and those types of things really came through as far as influencing job satisfaction. So I'm going to talk a little bit about the open-ended questions. If we want to move to the next slide here. We asked two open-ended questions. So, and let's see. In my opinion, the title of athletic trainer indicates the following professional roles and responsibilities. For people that are outside of the United States, they may not realize that the title athletic trainer has gotten a little controversial for us in the United States. I think there are people that are that take a lot of pride in that title and wear it very, very proudly. But then there's other ones who feel that it doesn't really accurately represent our roles and functions within the healthcare system, and it may limit us a little bit. And then also, we just want to give people the opportunity to tell us some things, and they told us some really, really great stuff. So I want to be able to present some of that. So we actually grouped the athletic trainer question responses by region. Okay, so the first one of the ones I just want to give an example. Somebody basically gave us the definition right out of the NATA site, which was a good way to go about it. If you look at another one, it's really more of a and click on that. Let's see. Everything, prevention, immediate care. And as you can see, there's kind of, if you look at, there's two things about the way athletic trainers in the United States kind of represent themselves, is like we're kind of a Swiss Army knife. We work 24 hours a day. We do everything within the healthcare system. And some people view that as being a very strong positive, but some people also view that as with that comes a maybe an underappreciation of our skill level when we're basically trying to do everything. If we go into Canada, the Canada responses, we felt that these were a little bit more balanced towards sport and less about maybe kind of being in charge of the entire healthcare system, and really focusing on performance, orthopedics, athletics, those types of things like that. Very similar to the responses of the United States, but really a little bit more of a sport focus. And then you look at the Europe group, and there really was a serious misunderstanding of somebody who holds the title of athletic trainer This first one is really aligns more with kind of a what we would think of in the United States as a human performance specialist or a strength and conditioning specialist or one of those types of things like that. Another response was a different type of physical therapist that really works in physical activity. Kind of really relates us to being a little bit more hands-on than a physical therapist. That's pitch side. And then another one of the responses really made very clear that the term trainer is used differently in different countries, and sometimes that can be a fairly misunderstood title. So obviously that just confirms some of the things that the argument that's happening in the United States happens. So the other thing, and what else would you like to tell us? And I think we group these into certain kind of families of responses. And the first slide I want to mention is really the positive nature of interprofessional collaboration. I think all of these three sample responses all identify that that it's important to work together, that it's that it makes for more effective treatment, makes for better understanding, and ultimately benefits our patients and the stakeholders we work with. But then we get to the next slide, and this is either stereotypes or you know, that things aren't so good. You know, we realize that interprofessional collaboration is important and it benefits our patients, but it might not be happening the way we think. So a lot of these responses had to do with, you know, we don't get recognition, we don't get appropriate payment for our services and for our background, and then you know, one of the big ones is that we are not recognized at our fair value in this last question. Then the next one talking about really, you know, once again builds on that it's morely on the negative side. You know, we're rarely compensated for all the different things that we're expected to do above and beyond our regular duties in the United States. You know, here's another one of those arguments for changing the athletic trainer to something other than that, where athletic is not in our title. And then talking about how interprofessional education could maybe break down some of those barriers and the stereotypes that come around our title and our perceived historical role within the healthcare system. So this is then we want to finish up with a little bit more positive ones. This is somebody in one of the athletic therapists from Ireland, identifying how positive interprofessional education, interprofessional collaboration with nursing and occupational therapy was, and how it made them deliver better patient care. And then another one, you know, really assist the individual to attain their highest functional ability, not feeding their ego. If you work on a team, you can focus on the individual needs, and that's what the ultimate goal should be. So the summary slide, and this entire thing was one person's comment, which we thought was really a neat way to wrap up. Sports medicine is multidisciplined. Athletic trainers, physical therapists, osteopaths, radiologists, team physicians, all working together. In my own practice, I have athletic trainers and physiotherapists working together. We can all learn from each other. And then he used a quote, listen to those who seek the truth, be wary of those that say they know the truth. So we're always learning. So I thought that was really neat that presented that. Here's our contact information. We definitely want to thank the experts who helped us validate the survey, and then everybody that participated in this survey. We were really grateful to a lot of our colleagues with the CATA. The Canadian Athletic Therapists really embraced this, and we got a tremendous response from Canada. So we were really happy about that. So we're happy to answer any questions, but we do want to thank everyone for attending this presentation.
Well, thank you very much for that great presentation, Gert and Anthony. It was awesome. We haven't got a lot of questions that come across on the chat line. There was one comment that was made from Jose Rodriguez, and it said health systems or education systems, professionals in sports sciences do not feel support IPC. I think what he was just trying to say, much what you were talking about, is sometimes the systems were not in support of the IPC just generally, so it wasn't being properly promoted and integrated into their experiences.
Yeah, and I think part of it is also the fact that that they're not configured historically to value these types of interactions, whether it be the way our academic departments are configured in universities or in sport organizations and in healthcare organizations. So I don't know, Gert, you've done a lot of research in this area. You can probably comment on that too.
Yes, I think this too. Also in Germany or Switzerland, the implementation of sports science is very hard, is very difficult, and I'm not aware of any big strategies to implement IPC, IPE, and in sports science or other professions working in sports science and sports medicine. What we did in Heidelberg was we designed, or we created a collaboration between Sports Science Institute and the study program Interprofessional Healthcare. So the sports scientists had the chance to connect to other students in other healthcare professions and vice versa. And these were first steps to implement this. However, there's much work to do, and we should do this work. Yes, that's right. But the systems do not support this. That's right.
Okay, there's a question, I guess, from Brian Metcalf. It says, as a biokinetist, we deal with a great variety of metabolic and orthopedic conditions together with special populations, and would we be recognized in Europe, USA, and Canada? I can probably just say one thing, is that the Biokinetics Association of South Africa was at one point in time a voting member of the World Federation of Athletic Training and Therapy, and when we evolved our bylaws and tried to really sort of provide a little bit more of a condensed definition of what we meant by athletic training and therapy. The Biokinetics Association felt that their scope was different from what we were doing, and so they withdrew as a voting member of the association. But we're really pleased that we've been able to bring them back, because they were strongly felt in an affiliation with the World Federation, and so they are now members as a allied health professions member of the World Federation. So I think that they looked at themselves as seeing somewhat of a different scope of practice, but saw that this scope of practice would be something that they would want to promote internationally as well. So I just wanted to hand that one off to make that comment before I hand off the comment to you, the two of you.
Yeah, you know, the categories we adopted in this is really based mostly on the responses. So like literally, if we would have had a large amount of responses from Africa or South America or Asia, they probably would have garnered their own category. One of the things in interprofessional education, there's actually a pretty strong group in South Africa that is engaged in IPE. I would encourage your association to reach out to that group, because they are very enthusiastic, and they're looking for more collaboration. So I would encourage you to do that, and you feel free to reach out to me via email. I'm happy to connect you with some of the people there. So, but they do have a really growing IPE community in Africa, and especially South Africa. I've met some of those individuals at some of my conferences I've gone to.
Great. Well, that's a great connection right off the bat there. Hopefully that becomes bears some fruit.
Also from my side, it's nice to hear something about kinesiologists. It's not very common in German-speaking countries in Europe. So it would be very interesting to stay in contact or to connect with kinesiologists. And yes, would be fine. As we have not this profession here in Germany or Switzerland, not that in this kind as in other countries, e.g. South Africa or Canada. Thanks for that.
Great. Just a couple questions that just came to mind for me. The one about the interprofessional interactions, the results that you have there, which were, were lower than most of the other groupings. Do you think that that might have a relationship to the level of recognition of the profession in each region? I mean, my experiences in the professional athletic training is well recognized in the US and similarly in Canada, athletic therapy is, but some of the comments that you got even in the open-ended questions are saying that in Europe that it's not nearly as well recognized, so that those interactions are not necessarily as positive as they could be.
Yeah, I mean, I think one of the things with that is our ANOVA table kind of acted as we expected. I think that's generally the way a lot of these surveys go. People view them as very positive, but then they realize that real life things don't happen as well as they should. But we do feel that we did sense throughout the entire study that there was some, our fields benefit from some kind of role confusion. And I think that may lead to some disillusionment of kind of the ability to collaborate with some other professions. And that aligns with some of the other papers I've worked on too. So Gert, do you want to comment on that at all?
Yes, this is a good idea from you, Glenn, that's also the recognition of ATs or other health professions may impact the negative interprofessional interactions. And we didn't assess this in detail, the interprofessional interaction scales about the stereotypes, the hierarchy, equal respects, and the communication, the open communication. But it's interesting what you say, it's the recognition of ATs, or in Germany, I can underline this, the recognition of sports scientists or sports therapists. The other health professions don't know much about our roles and responsibilities and our scope of work, our scope of practice. So this is an important point, and this is something that should be really improved in our future efforts to learn from each other and to know the roles and responsibilities of professions working in sports science and sports medicine, e.g. for sports scientists, the physicians should know what we are doing, physiotherapists should know what's the difference to them and stuff like this. And that's a good idea. It's really a point that should be discussed. It's the recognition of ATs, and this was also mentioned in several papers. Yeah.
Oh, thank you very much for those comments. I think just from the standpoint of the World Federation as well, and maybe not to open up a whole can of worms, Anthony, but one of the things that we've identified in terms of trying to promote the profession internationally is the whole notion of branding. And branding a title is certainly an important thing. And I know that even just in our own discussions here right now, we've used a bit of an acronym. We've used AT as opposed to a PT or an MD. So the fact is that we're branding an acronym, and it should be tied to a title. And we have in our own organization, we have organizations who refer to themselves in a variety of different terms. In fact, in our name, we even have two different terms in the name of our organization. So in terms of trying to get some of that branding and that recognition that allows us to gain some of that respect, and also allows us to interrelate, might be one of those points of discussion we may want to do. The other question is, what would you recommend to those who have AT programs but don't have any other medical programs in their institutions?
Tony, would you like to?
Well, I can answer that. One of the things IPE is when two or more professions learn about from and with. So basically, all IPE does not have to be an all call where you have as many professions as possible. Maybe find yourself a good partner. So, for example, in the United States, most of the local community colleges or fire departments train their paramedics. Working with those paramedics could be a good way to do that. There's likely some sort of nursing program around, maybe some sort of simulation activity with nursing. Maybe your students can help them learn orthopedics, those types of things like that. Psychology is another good. Counseling psychology could be a good intervention, and a good partner also. So speech pathology, you know, things, social work, things that maybe you don't think of as logical partners. If you come up with discrete learning activities with them, because the bottom line is we just want to get our students together to understand that there needs to be a greater understanding outside of our own profession if we really want to improve patient care. So, you know, find yourself a good partner, and then if good things start happening, then you can start building on that from there.
And also from my side, start with small steps. As Tony told, it must not be medicine on board. It's good to have medicine on board. It's a more powerful impact, I think, if you have this on board. But again, what we did in Heidelberg was that we linked sports science students with students from other health professions, and there were no medicine students. There were physiotherapists and OTs and nursing students. And so I can repeat what Tony said. So search for those who would like to collaborate, who would like to connect to each other, and it's a so-called champion. So you think of other institutions or faculties, so search for those who are really interested and those who are open-minded, and to try to build networks and search for those champions to support your ideas. Maybe there's an IP coordinator you can contact and build relationships, and yeah, start with small steps. And also, if you have research, you can handle this interprofessional, maybe with other students from other healthcare professions. So good luck, but start with small steps, yes, and go on and try to build those networks.
Great advice. This one is probably more of a comment than it is a question, but it just says, in my opinion, the curative medical side of patient care is expensive, and often chronic treatment cause more patient complications and secondary problems, whereas a preventative and educational approach can be more effective to disease management. We all know that exercise, lifestyle changes are more effective than some medications, but our roles as health professionals are often overlooked. And I think this goes back to speaking to, you know, the strengths of the profession, but the fact that it is not, and it's the value of prevention versus reactive type medical care, and how, again, we're not necessarily recognized as being the champions in those roles of prevention. I don't know if you want to comment on that at all, or.
I agree. That's great. That's a huge window of opportunity for us that are focused on physical activity and movement and prevention. I think the role that we play in the healthcare, though, I've been really lucky. We athletic trainers and athletic therapists and other people that are involved with sports science realize that we bring something unique and fresh to a lot of these interprofessional initiatives, and we need to move into that area, into that space with confidence. I think we bring a different type of clinician, we bring a different type of student into the mix, and I think it really transforms some of these interprofessional initiatives. And I think and just a comment, just the way you made was you know, that has much to add the traditional allopathic medicine kind of concepts.
Right. I've got a question here from Stephen Gleason. He's from Ireland. I'm a recent graduate from BSc in athletic therapy in Ireland. Our course is mainly focused on self-employment, mainly due to the lack of job prospects and recognition. Is this an issue faced on by other countries, and how was it addressed?
Yeah, I mean, I think one of the things we found with this survey that self-employment is and from other conversations I've had, is that it's a much bigger issue in probably, you know, it's a much bigger, more prevalent in Europe and Canada. In the United States, where kind of school sport is more established, likely, all the way down to the secondary school levels and those types of things like that. There's more employment there. However, if you talk to athletic trainers in the United States, they feel that they're often underappreciated in those settings as compared to maybe people holding other roles within those companies. So I think it's one of those things where I think you need to come at it from multiple angles. You need to provide opportunities for people to work for organizations. At the same time, I think in the United States, we're looking at growing business models for athletic trainers outside of school settings, because you know, obviously what's going on with COVID now, we you know, a lot of schools have canceled their contests, and it really creates a very tenuous financial situation. So you know, I understand probably why they focused on that in your curriculum, because that's a reality of in Ireland how some athletic therapy is delivered. However, I think you need to be vigilant and advocate for multiple venues for your profession.
Okay, if maybe some inputs from Germany and Switzerland, I can focus from the viewpoint of a sports scientist. I don't know the other curricula from PTs, OTs, and stuff like that, or dietitians. I know from sports scientists in Germany or Switzerland, I think there is not much focus on leading them to be self-employed, especially in the area of healthcare, of prevention and rehabilitation. Most students of sports science will focus on prevention and rehab, or health promotion, are employed at injury clinics or rehab clinics, or in rehab centers in the outpatient area. So from this point of view, from Switzerland and Germany, we have not that much focus on the self-employment in the future, in contrast to others like physiotherapists and so on.
And if I can give you a bit of a Canadian perspective, the self-employment is probably the largest job market for our graduates now, because working with teams, there's a finite number of teams that are available. As much as they're expanding, we're getting down to the lower levels of you know, amateur sport and things, so that there is an expanding market in that area. But still, I think the self-employment, opening up clinics is in a large portion of the employment opportunities. But also there has been a real trend to having interdisciplinary clinics, particularly with massage therapy, athletic therapy, and chiropractors, and to some degree physiotherapists. So there are a number of clinics now that have these multidisciplinary teams, so that you can access all of them. And they also, as we've talked about, having the benefit of having this interprofessional collaboration for the benefit of the patient. And so that has been an evolving trend over the last probably 5 to 10 years. But prior to that was the whole notion of recognition. So we had to be able to, each one of those professions had to know who the other one was, know what they do, what the differences were, and being able to say what were the benefits of, you know, having 1 + 1 = 3, that if we came together, we were better than the sum of our parts. And so I think that's something that's evolved, at least in Canada. One last question, I think, well, I think this is more of a comment again, sorry, but one of the areas that I found where interprofessional collaborations has worked at its best And where we've had this opportunity to have recognition has been in international games. I've been chief therapist at a number of Olympic games and a number of other games, and have had to, coordinate multiple professions under one roof for one purpose, and trying to make sure that we were always athlete focused. And that's always been a great opportunity for professions to be able to sit down and talk to each other, observe each other, and leave with a different perspective of how how they can work together. And I think the more we can have those kinds of opportunities, the better as well. I don't know if you have any, Anthony, if you had any.
That's a great point. I tell you, what I found is the people that work together, they appreciate each other. As the people that don't get that opportunity to work together and learn together are the ones who probably don't have as much of an appreciation of each other. I agree with you.
Yeah, concerning the athletes, same from my experience in the Olympic Training Center in Heidelberg, and the diagnosticians. And I think it was a good interprofessional exchange and interprofessional collaboration, as all were under one roof, you can say. So in these Olympic training centers, where the diagnosticians or the sports scientists, the strength and conditioning coach, the sports medicine physicians, in orthopedics, in internal medicine, we had the physiotherapists, and people who cared about the career of the athletes. And the sports scientist was, the sports institute was 100 meters side by the Olympic Training Center. So there was a good base for interprofessional collaboration and communication. You had all those professions side by side, and you could go to each profession and collaborate and communicate. So this athletic elite athletes area is a great chance to collaborate interprofessionally.
Okay, well, it's amazing how fast the time goes by when the topic is such an interesting topic area, and it relates to all of us. But I want to thank you, Doctors Breitbach and Ulrich, for a wonderful presentation, and thank you all of you for joining on this international webinar. Just a quick little commercial with the World Federation. Maybe if you want, Oliver, if you can do a stop share, and I'll just bring up our website really quickly. So I'll just bring up our website just to introduce people to the website. But the World Federation is celebrating its 20th anniversary this year, and as you see, we're dedicated to promotion of the profession of athletic training to other professions worldwide, so that we can really maximize this interprofessional collaboration. So if you have any, if you want to have a look more at the World Federation, please do so right on this website. We are, as the website indicates, we have 44 member organizations. We represent 12 different countries at this point in time, more coming on all the time. We've just signed a memorandum of agreement with Armenia, for example. We're on 5 different continents, and we represent over 50,000 ATs. So there's a number there. We are an entity. Our annual members meeting exactly tomorrow. So if you wish to join that, you're welcome to do that as well. And so please follow us. We are on Facebook. We do have a Facebook that's generated just for our academic institutions, so they can collaborate. But we also have our general Facebook, Twitter, and LinkedIn and Instagram. So please follow us on there so we can keep in touch. You can keep in touch with us, and we can keep in touch with you. We are currently, just to give you another commercial, we're currently working with Dr. Dennis Kane, who is a professor emeritus in kinesiology and public health at the University of North Dakota, for our next webinar, which is scheduled actually now for November the 18th. And it will be entitled Primary Facial Stress Injuries in Young Athletes. And Dr. Kane is very well published with a number of textbooks, etc., on epidemiology and particularly facial stress injuries in young athletes. So this will be a very interesting presentation. I will be sending out, we'll be getting out information on that very shortly. So I want to thank again Drs. Breitbach and Drs. Ulrich for a very informative session. And I wish you all the best in these challenging times. I know things are getting a little bit worse in some places, and we need to all work together to make this thing go away so we can get back to normal. So all the best to all of you. And just a reminder to please take a few minutes to respond to the questionnaire that will be sent out to you immediately after this presentation. Thanks very much. We'll talk to you soon.